responsible for the congenital heart disease patients here at the University Hospital in Lausanne. So he's also here with a project in the interventional MRI, and he will talk about using MRI or MRI data to maybe measure pressures and to help to get the estimation of congenital heart disease patients with these tools. Please, Tobias, let us know.
Yes, hello. So I will start my presentation. Do you see my slides?
Yes.
Yes.
Okay. So yeah, thank you very much for the invitation. It's really an honor to be here, and yeah, and also an honor to speak after Vivek, where we went recently, and with whom I have a long-standing collaboration. So I have the task to speak about pulmonary pressure, invasive or non-invasive, and I have no disclosures despite building some MRIs with my sons. So when we speak about pulmonary pressure, we have to speak about right heart catheterization, as Vivek already alluded to. It's available since almost 100 years, invented by Mr. Forssmann, who was actually a surgeon and a urologist, but who won the Nobel Prize for this right heart catheterization. And also, it's an old technique. It's still very important because it provides us very important hemodynamic parameters for many different cardiac diseases, with quite an easy access to the right heart, and giving us important parameters which we all know, which can help for different cardiovascular diseases, and in a very reliable way. And although its overall use has been declined over the last years by 40%, in some situations even 90%, it still has its role, particularly for patients with heart failure, like acute heart failure, or I should say cardiac shock, or for evaluation of patients who before heart or lung transplantations, and two patients group where I'm interested in patients with intra and extracardiac shunts, so and patients with pulmonary hypertension. And for pulmonary hypertension in particular, it's really the gold standard still, and even the most recent guidelines from 2022 noted that right heart catheterization has a class 1 indication and has to be performed to confirm the diagnosis of pulmonary hypertension, and also to help to understand which type of pulmonary hypertension is present in the respective patient. So it is safe. It is a very often experienced exam. However, it has some risk. And even in experienced centers, as had been shown in 2015, there is a risk of about 1%. Even these are minor complications like hypotension, bleeding, pneumothorax, or patient discomfort, but they also had 4 fatalities. So it's still an invasive procedure, which has to be kept in mind. And the other point is the radiation. As Vivek already alluded to, this is particularly problematic in children and in younger patients, and patients with congenital heart disease, or patients who require repetitive exam. As my colleagues in Munich nicely could show, or it's not nice actually to show the result, is that if you have to undergo cardiac catheterization as a child, you have an increased risk of cancer during your life compared to the general population. And we all think, as adult cardiologists, on patients who are 70 years and who have to undergo one right heart catheterization. However, in congenital heart disease, for example, it's not like this. Those patients, they survive to adulthood today, but they are not cured. They can have complications like heart failure, need for reintervention, arrhythmias, endocarditis, and pulmonary hypertension, which is increasing up to almost 24% in the age of 60, 70. So those patients need repetitive exams, and then radiation becomes actually problematic. So can we possibly evaluate pulmonary pressure and resistance non-invasively without right heart catheterization, and actually could we even replace right heart catheterization. So go a step further than what Vivek nicely showed with this fascinating way of augmented CMR right heart catheterization. So the alternative is there an alternative in cardiac magnetic resonance? And you all know that cardiac magnetic resonance is a fascinating tool, technique, the gold standard for the determination of volumetry, cardiac function, tissue characterization. However, what is also extremely important is flow measurements. And particularly in congenital heart disease, we measure flow in all these patients. Usually we use 2D flow in many vessels, which can be quite long, as you have to plan for every vessel the flow, and needs sometimes also patient collaboration. So there are new techniques which have been developed over the recent years, techniques actually who acquire a whole heart, providing, for example, anatomic information like a CT, as you can see here, with very precise determination of anatomy, like here you see a patient of a single coronary artery. And we now also have senior 3D whole heart, where we can actually also determine volumetry and cardiac function. And in the next step, or in parallel, several groups was developed 4D and 5D. So flow sequences were integrated into these 3D whole heart acquisitions. And there are basically two different types how you can acquire these data. The problem is that the acquisition lasts about, in the beginning, in the first years, it was 15 minutes. Now we often have sequence scan duration of 8 to 10 minutes, where we will need, during the scan duration, we will need to correct for the cardiac movement during the respiratory cycle. And the 4D flow usually uses navigators which are placed on the diaphragm to correct for the cardiac movement. And then the images are aligned. And there's another technique, the 5D flow, or the free running sequence, where actually the information on the heart position is extracted from the K-space, and also ECG, the ECG information, and we can have information, a volume over the whole respiratory cycle, and you can reconstruct nice images to visualize interesting anatomy and flow, like how you can see here of a patient with a double aortic arch, where you can see the flow going through the both parts. So we can use this 4D flow, or how can we use this 4D flow in pulmonary hypertension? And we can just very simple, for example, measure flow in the pulmonary arteries, as been shown here in this by this group. What they could show is, depending on which kind of underlying pulmonary hypertension type, the flow velocity was reduced in the main pulmonary artery and the right and left pulmonary artery, and it was less reduced in patients with left-sided pulmonary hypertension. However, 4D flow can also provide us more information than just simple flow information. We can obtain advanced flow information from flow dynamics, from secondary flow profiles like vorticity, helicity, kinetic energy, and its loss. As you can see here in a 4D flow of the ventricular flow, there are flow is not always laminar, and the flow forms a vortex during diastole, which is then converted into kinetic energy to actually propulse the flow through the left ventricular outflow tract. And one distinguished different flows, 4 different types of flows in the ventricle. We have the direct flow, the flow which enters the left ventricle directly and is ejected immediately during systole. There's the retained inflow. That means this is flow which enters the ventricle but remains in the ventricle and is not injected during the systole. We have the delayed ejection flow. This is flow which has been already in the ventricle and is ejected. And there's residual volume. This is flow, blood which actually remains in the ventricle for more than 2 cycles. And this can be quantified by 4D flow, the different components, and we can also calculate the kinetic energy. The kinetic energy represents the amount of energy in the blood flow due to its motion. And as you can see here is a curve of the kinetic energy during the systole and the diastole, with the determination of the peak kinetic energy during systole, and as we know it from echocardiography, the kinetic energy during the ventricular filling, so the E wave and the A wave. And this is, has been shown that this is actually disturbed in patients with pulmonary hypertension in the right ventricle. So this group, they showed in 2022 that compared to healthy control in patients with pulmonary arterial hypertension, depending on the right ventricular ejection fraction, the residual volume is increased and the filling is diminished. So the kinetic energy in the filling is diminished. And the right ventricular direct flow is also diminished depending on the right ventricular ejection fraction. So this can help actually to help to risk stratify patients, as when adding it to a model to risk stratify patients, you can increase the model to help to identify patients who are at risk for an adverse outcome. Of course, the flow is disturbed also in the pulmonary vasculature, and we can depict this with 4D flow nicely. We know that wall shear stress is diminished depending on the pulmonary vascular resistance, as you can see here in a patient who has pulmonary arterial hypertension associated to an ASD with the dilated pulmonary trunk. And we can show with 4D flow, with different techniques, the flow, how it becomes turbulent in this pulmonary vasculature. So what we can see here, that the flow becomes turbulent and it starts to form vortices. So these vortices are actually interesting. In a normal patient, you see that there is the flow is nicely laminar. There's no turbulences, and this is a patient with the pulmonary hypertension who forms vortices. And how can we use this vortex? Actually, we can use it very easily, or one way to use it is very easy. We can look to the duration, because what has different groups have shown is that the vortex duration actually is related to the mean pulmonary artery pressure. So the longer the vortex duration is in relation to the whole cardiac cycle, the higher mean pulmonary artery pressure is, as has been shown here in 2 patients from our colleagues from Geneva, where they, in a patient with a mean pressure of 46 millimeters of mercury, the duration was 60%. In a patient with a mean pressure of 26, the mean duration was 32%. And actually, this parameter outperformed many other parameters in predicting the presence of pulmonary hypertension. Also, they used the old classification, but you can see that the vortex duration performed better than many other very established parameters. Another group recently showed that actually this parameter helps you to identify patients with pulmonary hypertension. We usually screen patients with echocardiography, but often we determine or decide whether there is a probability of pulmonary hypertension depending on the velocity of the TR signal, often signal of the tricuspid regurgitation. And however, sometimes you don't have a good signal. And they showed that in this letter, which was published in JACC Imaging, that the CMR outperformed echocardiography in predicting the mean pulmonary arterial pressure. So this is so you can use your CMR to actually screen for patients who have a probability for pulmonary hypertension and who need an invasive evaluation. You can also use this vortex duration to follow your patients and to monitor your patients during their disease course. In this paper, the group of writers, they showed that actually they were able to depict very minor changes of the mean pulmonary arterial pressure during the time course. You know that pulmonary hypertension, unfortunately, despite that we have many very exciting new treatments, is still a progressive disease, and to monitor and to identify patients who actually deteriorate is extremely important. And here you could use your MRI to follow your patient and to identify the patients who are deteriorating. As we said before, the acquisition has come down to 9 to 8 to 10 minutes, which can still be relatively long for some of those patients. And a group recently showed that you can even accelerate your acquisition even more, down to low 2 minutes, and still detect the vortex and also calculate the mean pulmonary arterial pressure. And they showed that both the standard 4D flow acquisition and the accelerated 4D flow technique depicted or calculated the same mean pulmonary arterial pressure. However, this was not validated to the right heart cath. So is this all true, or is this actually fake news? Because this group questioned that actually the vortex formation is related really to the afterloop or to the pulmonary vasculature, and it's more actually related to the adaptation of the right ventricle and the pulmonary arterial system to the burden of pulmonary hypertension. And this is probably a very good point. And are there other parameters out which we could use to identify patients to pressure? And yes, there are. There is two parameters which are mainly investigated. There are many different parameters. One is vorticity. Vorticity is defined as the curl of the velocity quantifying the rotation around the nexus of the individual fluid particles. And helicity is defined as a parameter which quantifies the helical flow, or the flow with a corkscrew-like motion in one direction. And this is proportional to the velocity and vorticity, and actually reflects the stability of a laminar flow. So different groups tried to look whether those parameters actually can help to identify patients. And a very important publication is from the group of Schäfer in 2017, where they actually evaluated vorticity and helicity. And here are some images from their publication where you can see the velocity maps and the vorticity map in a patient in the main pulmonary artery and both right and left pulmonary arteries, and the curve of the vorticity. And what they could show in their paper, in their group, or patient group, is that helicity was reduced in patients with pulmonary hypertension in the main pulmonary artery and the right pulmonary artery. Vorticity actually was quite similar, beside in the right pulmonary artery. Another group showed that in the same, more or less same time period, that in their patient population, vorticity was related to the pulmonary vascular resistance in the right pulmonary artery and in the main pulmonary artery. And they were able to build a model, a multivariate model, to compare right heart cath derived pulmonary vascular resistance versus the function of vorticity in main pulmonary artery, in the right pulmonary artery, cardiac output, and the relative area change in the main pulmonary artery. So this is still quite a complicated algorithm, and for sure not ready for to be used easily in the clinics. An important point or important feature of the right heart catheterization is actually to differentiate what type of pulmonary hypertension we have. As you know, particular pulmonary hypertension with left heart diseases behaves completely different from the other types, and the treatment is completely different. So is it actually possible to differentiate whether we have a patient with us who has a precapillary or postcapillary pulmonary hypertension? And it seems to be possible in a recent publication from this year. It was shown that actually the vortex volume and energetics allow to distinguish whether the presence of pre or postcapillary pulmonary hypertension, which could be very important to distinguish the patients. So you can also use those parameters to follow patients after, or to evaluate patients after treatment interventions. And a nice model is patients who have pulmonary arterial hypertension due to chronic thromboembolic disease. And in this publication, it was shown that actually they showed followed patients before and after percutaneous enterectomy for CTEPH. And it was a very complete protocol where they obtained many different data on volumetry, flow, and secondary flow profiles, so also vorticity and helicity. And what was what they could show was that their patients replied to the intervention, so the mean pulmonary artery pressure and the vascular resistance went down after the intervention. And what was interesting is that they could show that the vorticity improved after the intervention, and also the helicity. They used a little bit a different parameter of the helicity, only the positive fraction of the helicity. But as you can see nicely here, I think everybody agrees that the flow on the right side looks much more laminar than it was before the intervention. So invasive exams by cardiac heart catheterization are still nowadays necessary, even though that we are almost 100 years after the introduction of this technique. But we have risk, and there's also, although they are quite minor. And advanced flow parameters from 4D5D could help to understand better pathophysiological mechanisms. However, we need to validate them, and we have, that's the reason why I'm here today, a project where we want to simultaneously acquire flow parameters and advanced flow parameters to invasive hemodynamic parameters to validate really with, and to try to identify the best parameter or the best parameters predicting pulmonary pressures and vascular resistance. So to conclude, is it possible to non-invasively evaluate pulmonary pressures and resistance? Probably yes, but we still need validation. Could we replace right heart catheterization? Maybe yes, for at least monitor screening, for example, which patient needs right heart catheterization. We could probably still already today have an idea how CMAR could help us to identify patients, and also for the monitoring of patients after treatment implementation, we could use CMAR to follow our patients. But we need to prospectively evaluate those parameters. So I thank to all my collaborators who will participate in our very ambitious project. And yeah, we said we just went to London to Vivek Center, and I will hopefully be able to provide new results of our study in the future. Thank you very much.
Thank you very much, Tobias. It was a great talk. I learned a lot about new things, and I was surprised how many different aspects and concepts are under investigation for this technique. And I think with all these parameters, we learn a lot about the physiology of phenomenon that we thought it's easy, it's just hypertension, but it's just much more than that. So it's quite interesting how many different approaches are done. What do you think? Would it be a good idea to acquire a large set of data in this MRI, and then to use some unsupervised learning algorithms to find parameters that best correlate or predict hypertension? Or should we just test velocity, helicity, and so on? Or should we run AI to just search in all the data which combination of data would best predict would best predict pulmonary hypertension?
I think a combined approach would probably be good. So the problem is that we all those parameters and also the hemodynamics are extremely sensible to loading condition. And the problem is that often, in some studies, unfortunately, the time between the right heart cath and the CMR, there was some quite a significant time in between, and it would be probably difficult to obtain currently sufficient number of exams to provide a neuronal network or whatever with enough data to actually train to identify the best parameter depicting or identifying pulmonary hypertension. What Vivek already alluded to, I think we need more centers doing CMR right heart cath. We could then maybe combine forces and try to identify the best parameters. Yeah, I think this is a little bit the issue of sampling enough data to train networks with sufficient data. And then the patients' population are very heterogeneous. These are often rare diseases. So at least in one center alone, it would be difficult for big data sets. So, but in the future, it would be important to probably combine forces and do multi-center studies.
Just a question. For this flow, can reliably calculate pulmonary artery resistance? Because this is a main problem. I mean, we don't need only the pressure, but also the resistance. And avoid finally the catheter.
Yeah, this is all the pressure, the problem that we cannot determine the pressure, and those parameters are only estimating the vascular resistance. So based on flow profiles which are found to be typical for specific subtypes. That's what we will try to show with our project, that we try to really look which of those advanced parameters correlates best to or depicts best increased pulmonary vascular resistance. But the main problem is that we don't have the pressures, unfortunately.
Dr. Rutz, I heard carefully your nice talk and your presentation. I was considering that first as we have to recognize, still right heart catheterization is the gold standard to measure pulmonary hypertension. The second, although very early, artificial intelligence at the moment is doing progress in this field, and several AI models have been developed to calculate pulmonary hypertension based upon echo measurements, correct? Echo measurements.
Yeah.
Imaging-based AI models, among those and MRI, and ECG-based models. So what's your opinion? Do we need at the moment MRI, which a little bit more complex technique to calculate pulmonary hypertension, if at the end we had the opportunity to calculate pulmonary hypertension through AI combined with echo measurements?
I think there's this is a very good question, but I think MRI offers not only, as Vivek already also told, we have in the MRI, we don't only have, compared to right heart catheterization, the resistance and the pulmonary pressure, but we also have all the other information like the right ventricular function, the right ventricular hypertrophy. We know that this is predictive for the outcome. We have septal curvature and things like this. So we can really give a complete workup and acquire a lot of prognostic parameters. So if we could combine those parameters with the estimation of pulmonary pressure or pulmonary vascular resistance, I think we could offer a very complete workup in those patients and provide a lot of prognostic parameters. So I think it's always in medicine, and I'm also doing a lot of echocardiography, so I like echocardiography. It's always a combination of different techniques, and I think what has been shown a lot in medicine, that there's rarely just one parameter sufficient to risk stratify our patients today, and it's a combination of different parameters. And I don't think that I think it's the MRI will have its role and will keep its role in evaluation of patients, and it's going to be probably a combination of different modalities and parameters which can help us to identify patients with pulmonary hypertension, and also, which is important, to follow them up during their time course.
Thank you.
Very good. I think we don't have questions from the audience at the moment. So Tobias, thank you very much. It was very informative, very good talk. Thank you. And
thank you very much.
We can move on to the next